Welcome, everyone. We hope you are all staying safe and well, and thank you for joining us. I am Victoria Ravis, one of three New York Aging Incubator co-directors, alongside of John Chodosh and Bei Wu. If this is your first time hearing about the New York Aging Incubator, I'd like to briefly take a moment to introduce our initiative. The incubator was established in 2016-17 as a university-wide initiative bringing together faculty, students from across the university and from all disciplines who are involved in the study of aging and its impact on society. The Aging Incubator aspires to be the resource for the New York community to grow research, educational activities, events, and resources for all who work in the aging space or are interested in doing so. We're committed to the improvement of the health and well-being of older adults through both innovative and interdisciplinary research, policy development, and educational endeavors. On behalf of the NYU Aging Incubator team, I'd like to welcome you and thank you for joining our webinar today. I'm pleased to introduce our guest speaker, Dr. Anat Lubetzky, Associate Professor of Physical Therapy at NYU Steinhardt and a Fellow of the Aging Incubator. She is currently studying the contribution of sounds to postural control, focusing on hearing or vestibular loss in different contexts. She is applying the knowledge gained to balance rehabilitation of people with vestibular disorders and fall prevention in people with hearing loss. Today, she'll review recent evidence regarding the link between hearing loss and increased fall risk. Following her presentation, we'll hold a brief Q&A session during the final minutes of the webinar. Stay tuned also for our next fall speaker series presentation. Vidal Lim, Clinical Associate Professor at NYU Rory Myers College of Nursing, is going to present on aging in the LGBTQ community. And please visit our website for more details. At this point, without further ado, I'd like to give Professor Lubetzky a few minutes to introduce herself and then do her presentation. Professor?
All right, thank you so much, Victoria, for this introduction. It's 11:59. I'm a noon sharp kind of person. Oh, there you go. We're ready. So I'm going to share my screen with sounds because we'll have some sounds. So there you go. Can everybody see the screen? It's interesting because I can't see people, but if you have any questions, please put them in the chat and I'll try to answer them as we go. And I hope we'll have a discussion at the end too. So super excited to be here this Friday afternoon to talk to you about hearing loss, balance, and the increased risk for falls. As already mentioned, I'm a professor at the NYU Physical Therapy Department, and I'll walk you a little bit through how we got to these questions and kind of this journey in balance and hearing loss, but mostly I want to give you an overview of where the literature is and as well as some practical clinical implications at the end. And so the overview of this next hour will be, first, we're going to look at the current state of the literature about hearing loss and the increased risk for falls, and of course the gaps in the literature and where my team thinks we should go from here. One of the points that mostly interesting to me and kind of the focus of my research is suggested mechanism. If hearing loss and falls are indeed associated, what might explain that relationship? And so we'll definitely talk a lot about that. Finally, I'll introduce some kind of preliminary evidence from our lab, a few small studies we've done and mostly where we're going. And then, as I said, practical implications. So let's get started with the current state of the literature. So I don't know how many of you are aware of this relationship. It was certainly the question of sound and balance was new to me 3 years ago, but apparently there are quite a few studies, especially some of these large longitudinal, national survey-based studies that have demonstrated consistently a correlation. So I picked the words here very closely, a correlation, so relationship. We don't know what, a cause and effect correlation between hearing loss, increased risk for falls, balanced dysfunction, or some impairment in factors that are related to fall risk. So I can talk with quite a bit of confidence about this relationship. But there's the question, is this an independent relationship? And we'll touch upon that point repeatedly during the next hour. And understanding the nature of this relationship will have major implications to public health. I'm not going to talk a lot about falls in public health. I'm going to assume that if you joined me today, you understand the risk of falls and you understand the implications of falls to public health. I picked a few numbers, but there are many. So the CDC reports that more than 1 out of 4 older people falls every year. Interestingly, less than half actually tell their doctor. So falls can lead to serious injuries, can lead to death. And if you're one of these, if you fell and you didn't report that to your doctor and kind of have not addressed that, falling once doubles the chances of falling again. And beyond injuries and the risk of death here, of course, then we enter this, what we call in rehab, the vicious cycle of fall, where you have a fall and then that creates fear of falling. With fear of falling comes decreased activity, cautious gait, slower gait. That is associated with loss of strength, reduced mobility, reduced participation in the community, not doing the things we love as much. So there's also risk here for depression and isolation. And with that comes increased risk for falling and then another fall. And we in rehab are really committed to breaking this cycle. And if hearing loss is indeed an increased risk for falls, then perhaps treating hearing loss can reduce fall risk. And that's what I mean by, this could have major implications for public health. I asked the question of whether this is an independent relationship. And so can't talk about hearing loss and vestibular loss without having an ear. So here's an ear. Why did I put an ear here? So when I ask if it's an independent relationship, I think most clinicians, before looking at this line of research, when you would ask them about hearing loss and falls, they would immediately think about their inner ear or the vestibular sense. The vestibular sense, it coordinates head and eye movements, coordinates body and eye movements, and is extremely crucial for our balance. It so happened that the hearing and vestibular system are extremely close anatomically. They are, in fact, entering the brain through one nerve, but then each one of them does its thing. They happen to be in the ear, but vestibular sense and the ability to hear are two separate functional systems. And so while they could be disrupted together, so it is often to get, say, hearing loss and vestibular loss on one side, if there's damage to this nerve, they could also be disrupted separately. So we have patients with vestibular loss and absolutely perfect hearing. We have patients with hearing loss and their vestibular system is functioning fine. And vestibular system, we're thinking about, people who have vestibular symptoms would have dizziness, would have loss of balance, would feel uncomfortable in busy environments. And so whether the relationship between hearing loss and falls is navigated through a vestibular contribution is something that we are looking at. And I'll show you where in the literature this was addressed or not, but it certainly needs to be part of the question here. We are trying to understand if there's an independent relationship between hearing loss and falls, meaning does hearing loss lead to increased fall risk? So now that we looked at an ear, we're gonna start reviewing some of the literature. I picked a few fundamental ones. There are more, there's more evidence that I can present in this 1 hour, but one of the first or kind of seminal work in this area came from Lynette Ferwutze in 2012. They had this large survey, 2,017 participants, recruited over 3 years, actually younger adults, 40 to 69-year-olds. What they found, I'm going to say it and then I'm going to explain. So for every 10 dB increase in hearing loss, there was a 1.4 increased odds of an individual reporting a fall over the preceding 12 months. Right? So they've recruited people over 3 years, they measured their hearing, they asked about falls, in the past 12 months. So what does an increase of 10 dB mean? Here on the right-hand side, I have the hearing loss grades as they are determined by the World Health Organization. So when we measure people's hearing, we presented at different frequencies, and we increase the intensity or loudness measured in dB until the person can hear. And normal hearing would be anywhere between 0 to 20, 25 dB. And then 26 to 40 dB is considered mild hearing loss, according to the World Health Organization. 41 to 60 is moderate. About 70 dB is pretty much a dead ear. They won't be able to hear anything on that side if it's one-sided, and then over 81 is considered profound. When we do these numbers, we usually take the average of 4 frequencies, so 0.51, 500, 1000 kilohertz, 2000 kilohertz, and 4 kilohertz. So 2000 hertz, 2 kilohertz, sorry. So that we look at the average of these 4 frequencies. So a change in every 10 dB increase worse hearing loss by 10 dB, 1.4 increased odds of an individual reporting a fall over the preceding 12 months. I hope I gave you a sense that that's a pretty meaningful finding. And they did adjust for other factors that might affect balance. They did consider, I mentioned the vestibular issue. The way they measured vestibular balance function was the ability of a person to stand on foam. Often it's actually this specific foam, standing on foam with eyes closed, which has been used in the literature as an indication of vestibular function, although we can talk about it at the end if you want. It goes a little more in depth than we have time for at the moment. But I, as a vestibular researcher, we in our group, we don't consider standing on foam with eyes closed as a diagnostic vestibular test. People could have difficulty standing on foam with eyes closed, even if they have no vestibular loss. So there could be other reasons, but they at least, mentioned the vestibular concept, and it did not change this relationship. So this is a large study. Then in 2016, another large study, 2,000 participants, a little bit older, 70 to 79-year-olds. This is a 10-year database. What they saw is that people with moderate or greater hearing loss, when they compare them to normal hearing, they found a 63% chance of developing frailty. Frailty in this study was defined as gait speed below 0.6 meter per second. That's pretty slow. We consider anything below 1 meter per second as something that could indicate increased fall risk, and or inability to rise up from a chair without support. And these people with moderate or greater hearing loss also had greater odds of falling over time. So 9.7% versus 4.4% in people with normal hearing. They did not adjust for vestibular function. They adjusted for other things such as age, although the age range was pretty limited already, demographic characteristics, cardiovascular risk factors, and so on. This is an kind of a picture of how we measure hearing, so audiometric exam. And you could see normal hearing. So these are the frequencies. This is the dB. Normal hearing is typically between 0 and 20. This particular example is from a patient that has hearing loss on one side. So here the hearing stayed normal, and the other ear kind of goes down and down with the frequencies until no hearing at all. So these were 2 studies showing relationship between hearing loss and self-reported falls. Lee et al. In 2013 looked at hearing loss and gait speed. They had 1,180 participants. They were, again, younger, 50 to 69 years old. And they underwent a hearing test and gait speed assessment. And people with hearing loss were twice more likely to have gait speed that's less than 1 meter per second, which is what in PT, in physical therapy, we considered increased fall risk. And they also came up with this assessment that the reduction in gait speed, it was associated with 25 dB worse hearing loss, was equivalent to that associated with an age difference of approximately 12 years. So that seemed like a pretty large effect size, but they did not adjust for other factors. So all of these large studies, we should consider confounders. Finally, a couple of examples related to hearing loss and balance or standing balance. A survey from South Korea published in 2020 had 3,384 participants, of whom, even though that looks like a very large sample, of whom 127 participants were classified as postural instability. So this is, again, you're standing on phone with eyes closed. So postural instability was defined as inability to stand on phone with eyes closed for at least 20 seconds. And interestingly, 101 out of these 127 had some sort of a hearing impairment. So that's about 80%. They did not adjust for vestibular function or other things. In 2009, a study from Finland had 429 women, average age 68.6, and those with poor hearing acuity, which could have been on one side or both sides, worse than 27. So if you recall, it's not a test, but if you recall the World Health Organization criteria, above 27 dB, that could still be mild hearing loss. They presented with high postural sway, high velocity, so kind of moved more, were less stable when they were standing in this position. So this is what we call heel to toe tandem position, as compared to women with normal hearing. So we had a few examples about self-reported falls, a few examples about, or one example about gait speed, a couple of examples about balance. There are quite a few more systematic reviews on the topic. I just feel compelled to present some conflicting evidence because there always is, and there's still work to be done. In 2019, Hitz et al. Actually did not find an independent association between self-reported hearing loss and falls after accounting for vestibular function. So as I mentioned, this is still an ongoing question. In this study, they defined vestibular function based on people reporting having vertigo or dizziness. And then in 2004, Purchase Helsner et al. Did not identify hearing loss as a risk factor for fracture or falls in older women. So there is a little bit of conflicting evidence and certainly great variability in the literature. But at this point, November 2021, there is enough evidence to suggest that hearing loss is certainly an important factor to consider when we try to prevent falls and identifying fall risk. And so the next question is why? What is the suggested mechanism that might explain that? And so this slide is kind of my lab guiding slide. In my lab, we have several ongoing studies attempting to answer this question, and each study actually kind of looks at a different possible hypothesis or possible theories to explain this relationship. I'm very fortunate to have amazing collaborators. I'll show my team at the end, but very strong clinical partnership with the New York Eye and Ear Infirmary of Mount Sinai. I've been working with them for many years, as well as strong partners at NYU. And so let me explain our model a little bit. So hearing problems and hearing loss, we think could be associated with one of these four explanations, and maybe more than one. I already explained the possible vestibular link, what we call underlying vestibular dysfunction. And so to me, moving forward, every study looking at this relationship between balance and hearing loss must address the question of vestibular function. So in whatever way, you can ask people about dizziness, so symptomology, or you can actually screen for vestibular function. There are some diagnostic tests of the vestibular system. So these things need to be considered. Another thing that we do is we include people in our studies that have known vestibular disorders and kind of compare their performance to those with hearing loss who have no vestibular complaints. The theory I'll talk about the most today is the sensory one. I'm a sensory integration researcher. We all know how important vision is for balance. We all know how important the vestibular system is for balance, and we talked about it. Information from the ground, somatosensory, right? That's the kind of the triangle of sensory integration. So the question here is, does what we hear matter for balance? When I walk down the street or when I stand, do I actually utilize sounds to balance myself? And there's actually a lot of literature about this. I'll show you in a little bit. But the theory here would be people with hearing loss are at increased risk for falls because they're missing important environmental cues that affect their balance control. So we'll talk more about that. The other two theories, well, one talks about cognition, and that's a whole other world. We do have a couple of studies looking at that. We could have a separate session talking about cognition and hearing loss. There are some studies showing relationship between cognitive loss and hearing loss. And so there's also a relationship between cognitive loss and falls. So is the relationship here navigated via cognitive loss? That's another possible theory. And then lastly, attention, which suggests that as we kind of go about our life, there's this just right amount of level of attention that we're supposed to dedicate to balance. Balance is somewhat automatic, but we still use our higher level brain to control it. So I'm supposed to kind of control my balance in a way that I have enough resources to respond to things that happen around me, but not think too much about my balance, if that makes sense. And there's some evidence, I'd like to show you a little bit, suggesting that people with hearing loss have issues with how much attention we're supposed to dedicate to standing and walking. Is it too much? Is it too little? Maybe because kind of part of their attention is already taken to, I need to pay greater attention to the environment because I'm missing hearing. So again, this is the main focus of my research. And now I'm going to talk a little bit about, does what we hear matter for balance? In 2020, we actually published a systematic review about this. There were 28 studies, and the findings were very interesting. So first, there was some evidence regarding static sound. So you know how if you're feeling unstable, you can focus on a stable visual cue, say a picture or a dot in the background, and that will help you stabilize yourself. That's well known for visual cues, for the visual system. There is a possibility that the auditory system works in a similar way. So there are some studies showing that a fixed, stationary, so not moving, broadband noise. Now I'm going to take you a little bit into the world of noise. We certainly learned a lot about noise when we wrote this review. Broadband noise could be white or pink. White noise is a sound that combines all audible frequencies with equal intensities. And this is what it sounds like. Pink noise is a sound that also combines all audible frequencies. However, the intensity decreases as the frequency increases. This mimics the way our auditory system perceives sound. You may or may not notice the difference. So it's a little softer. And actually, if you're interested, YouTube has 10 hours of pink noise for better sleep. So it is something that's out there. I wasn't familiar with, so many colors of noise before we started this paper. But the idea is that it's a complex sound as opposed to a pure tone, which has just one frequency. These sounds have multiple frequencies. So either these or natural sounds all have been shown to reduce sway, especially if you place them in a speaker in front of the listener or around the listener. So that's interesting. Likewise, there were some studies that show that dynamic sounds, much like we know with vision, could make people sway more or be a little less stable. So dynamic sounds would be, say there are two speakers, one on either side, and they jump the sound from one side to the other, or from the front to the back, or half an arc in front of me. There was a lot of variation. And this seemed to work well, especially with this kind of large array of speakers, maybe not as well with headphones. But it was a pretty consistent effect, not as large as vision or somatosensory, say changing the surface, but it certainly it was there, and the role of auditory cues seemed to become more important when there's a sensory conflict. So basically, when the balance task is more challenging, say back to the phone with eyes closed, it's a very popular way of measuring balance in rehab. So standing on phone with eyes closed, you're probably gonna be influenced by sounds more than when standing on the ground with your eyes open. And maybe even more interesting, when someone has a different sensory loss. So the effect was greater in people with vestibular dysfunction, that we mentioned already, people who are blind, so they cannot use visual for balance. So that has interesting implication by itself in terms of sounds and balance that go beyond hearing loss. Potentially can be used sounds to help improve balance in this patient. So we can talk about it at the end, but that's the current answer that I have for does what we hear matter for balance. Seems like it does, maybe not as much as vision. So next I want to take you to discuss some evidence from our lab. And so I mentioned my strong partnership with New York Eye and Ear Infirmary of Mount Sinai. I'm also very lucky to have a very strong technical team from Steinhardt Music Technology, from Courant Computer Science. So I'm very lucky and very proud of my team. We now have kind of two approaches for research. One is what we call in-clinic survey study. And actually this type of what you could consider messy, less eligibility dependent kind of thing, research that we do, we kind of started in April 2020, which I think we all know what April 2020 was like, when we thought, okay, where is human motion research going? Will people even come to the lab and do this research again? And while NYU was shut and the lab was shut, the clinic at the Ear Institute was open and running, and we thought we could utilize the fact that we have a portable design for research, and I'll show you a little bit about how we use virtual reality for that purpose, to test people where they are. So they already come to the clinic to see the doctor, to see vestibular rehabilitation, and we kind of ask them to stay for half an hour. So in this survey study, we include everyone that has different types of hearing loss, different type of vestibular disorders, hoping in the long term to have this differential diagnosis mechanism. And then we also have an in-laboratory study focused on unilateral hearing loss or unilateral vestibular loss. That's a cleaner study. We had to stop the study, I'll show you, we had to stop it in March 2020 and kind of managed to finish it in this past summer, and now we're moving kind of to the next phase. So thankfully, people are back in the lab, and we're able to do more research. Hopefully, that continues to improve. And so let me tell you some results, acknowledging that this is preliminary and pilot kind of work, but it does sit well with the literature that I've shown you so far. So as I mentioned, in this survey study, number one, patients enrolled as they came in to vestibular rehabilitation or the physician. They all performed two kind of super common functional balance tests. Both of these tests are quick to do and can tell you kind of about people's function, as well as have known cutoffs for fall risk. And they all underwent audiograms, by the way, as part of their care. And then we classify their hearing as per the American Academy of Otolaryngology head and neck surgery. So that's the classification. We already mentioned the PTA, right? So below 30 dB, that's hearing class A, which is essentially normal or very mild hearing loss. Then we had 30 to 50, which is more moderate. And then above 50, severe, and this is profound. And this is word recognition score. And then above 70% is good. Most of the people we see that have normal hearing have 100% word recognition score, 96%. And then around 50% is hearing level B and C, and below 50% is hearing level D. I also want to show you, to those of you who are not familiar with this test, this is the time up and go. So you tell the patient to rise up from a chair, walk around the cone, and sit back down, and you time them with a stopwatch. This is done in comfortable speed, and we in PT loves this test because it combines a lot of things. First of all, normal, comfortable speed. Secondly, the ability to turn around, getting up from a chair, sitting down. If you recall, we talked before about slow walking or inability to rise up from a chair without support as kind of indication of frailty. So there are a lot that goes into this, 7-second test. And above 12 seconds is considered fall risk. The second test is the one that people always laugh when I demonstrate, because I used to be a step aerobics instructor and I look like an aerobics instructor when I do it, but this is the 4-step square test. And so a little more coordination, need to remember the pattern, need to step over a cane, need to do it as fast as possible. So while these tests are often correlated, they're really not the same. So if someone is kind of normally walking a little slower and that's healthy for them, here things may come up because we ask them to move as fast as possible. If they hit the cane, it's disqualified. So they need to kind of, lift their leg to the side, lift their leg to the back, and so on. So these are the 2 tests. This is a large sample, but it's very mixed. And so the first thing I saw was this figure, which, you get your data. The first thing you do is you plot it. This figure was really interesting because, it's one thing to find a significant difference. It's a whole other thing to find this gradual. And if you kind of look back to slides 3, 4, that happens a lot in this type of studies. It's not, some studies look at yes, no hearing loss, but many studies show this gradient effect. With the worse the hearing loss, the greater the risk. So this is hearing class code from A to B to C to D. So D is the worst, and TUG, time up and go. And just descriptively, I'm not talking statistical significant yet. It seems to get worse as the hearing loss got worse, which of course I always doubt all the data. So I said, oh, this must be explained by age, but it wasn't. I thought maybe the D people were older, because older people would do the TUG slower, right? But it wasn't all explained by age. This is mean age. And you see, we had a diverse age range, and yes, the A group was younger, but at least the B group and the D group were completely comparable in age. So there is something interesting there. It's not a clean study, so I can't talk about cause effect. That we still need to explore this. And we have to consider the numbers. So large study overall, but when you start breaking it down into the different hearing levels, then it gets a little smaller, right? So there were 60 patients in the A, and actually many of them had vestibular loss. 17 had vestibular loss alone, 15 had combined vestibular loss and hearing loss. Then there were only 12 in hearing class B, 9 in hearing class C, and only 5 in hearing class D. So that's very small. Actually, one of them couldn't even do it. That was the only group where a patient couldn't do the test. So it does suggest something. I have to say, remember that the vestibular patients come to this clinic for balance rehabilitation. The patients with hearing loss do not. They come to see the doctor. They come to take care of their hearing. They don't come for balance complaints. And here are the results with the FSST, the 4-step square test. So again, D was significantly slower than B, even though they were of similar age, but again, very fewer patients in the D group. If we are concerned about age, this little study actually looked at the young people only, 9 people with single-sided hearing loss of different levels. Some was actually not very severe, 4 with vestibular hyperfunction and normal hearing, and then 9 that were healthy young adults, 7 that had some unilateral hearing loss, but they're all in their 20s. So, nobody in their 20s think about balance. I certainly didn't think about balance when I was 20, but you know what, maybe I did. Was I a PT already? So the people with the hearing loss were slower. They were slower than those with vestibular hypofunction. Again, they didn't come there for their balance. They only did this because we asked them for the study. So we had a significant difference between hearing loss and controls on the FSSD, and kind of a trend. This is a much smaller sample, and they're much younger. But it's interesting. I mean, for a young adult to perform the time up and go at 11 seconds, that's slow. That's slow. So we need to start looking at these people, and in the future also understand who of them are at increased fall risk, right? Because it's never everyone, but these findings were interesting. I'm next going to show a little bit of evidence from our laboratory study, and this study included 21 healthy controls, 9 people with hearing loss on one side that was at least severe, so 50 dB or up. They could not hear out of that ear, and then 12 people with vestibular hypofunction and perfect hearing. This study was funded by the Hearing Health Foundation in 2019, and what we looked at is changes in postural sway and actually also head sway in response to 2 levels of visual input, 2 levels of auditory input, and 2 levels of somatosensory input. So that's standing on floor or standing on a compliant surface on foam. So that's considered kind of taking away the ground. And we wanted to see how people respond to these different stimuli. So this is the experimental setup. Hold on. This is the experimental setup. People are standing on floor or on memory foam. Maybe by now you're familiar with the foam. This is a laboratory force plate. They're wearing the HTC Vive. This is our lab in the PT department. And so this is the scene. So 2 levels of visual stimuli both had this display of stars. I feel like I've been studying the stars for many years now. My entire PhD was different amplitudes and frequencies of stars. This one is moving front to back. It has 32 millimeters movement at a frequency of 0.2 hertz. So 0.2 hertz is a pretty comfortable frequency for a standing individual. That's usually where we move. 32 millimeters is certainly noticeable, but it's not something that's going to make you fall unless you have a severe balance problem. So it's a very subtle perturbation. This specific scene has been studied quite a bit. We just translated it to a virtual reality environment here with the HTC Vive that also has headphones. The sound was more of an open question. What we did here together with our music team. So there's 2 levels, no sound or this rhythmic moving sound. Our idea with that was to match the movement of the visuals. So that it had a frequency of 0.3 hertz, so a different frequency than the visuals, and this whoosh was an intensity change of 1 dB. People said it feels like someone breathing behind them or someone sweeping the floor. To be fair, at the end of this pilot, we realized that these specific sounds didn't do anything. So it might be because it's not moving enough, or maybe because it's headphones versus speakers. We're studying now different types of sound, so we can talk about that, but I can kind of spoiler alert. These specific sounds didn't do anything, but I do want to talk about what the visuals did. And remember, pilot study, small sample, have to say they are matched for age. That's always a concern, right? So the average is kind of around 50. And I love it when one figure summarizes an entire study. And what's nice is that all of the outcome measures we looked at looked pretty much like that. So let me take you into the world of sensory integration, weighting and reweighting, and explain this figure. We're looking at measure that's called directional path. Directional path is when I'm standing upright, directional path is how much I move in a given direction. Here, our primary outcome is front to back or anterior posterior, which is, we made it primary because the visuals, as I showed you, are moving front to back. And by the way, I have to acknowledge that, you know, looking at these visuals in a 2D computer screen is not as powerful as being inside of it, as wearing the headset. So directional path front to back in centimeters. Let's look at the control first. This is static visuals, so the stars are not moving, and this is dynamic visuals, right? The two levels of visuals. Because the sounds didn't make a difference, we combined that data. When we introduced the visual movement, there was a small yet significant change in the control group's sway. So they moved a little more with those visuals. Then the blue line is when they're standing on foam. Foam is a very powerful perturbation for any individual, super healthy, super young. Standing on floor on foam versus standing on foam will always have a major effect size. So kind of this was not the interesting question here. It was obvious that once we're standing on foam, we're going to have more sway. And you know, the holy grail of sensory reweighting, once I take away the ground, people tend to rely more on vision. And so this is obviously a larger effect size in response to the visual stimulus when standing on foam. So great, this kind of confirms that other than the sounds question in terms of visual, we kind of got what you would expect with normal weighting and reweighting. This is the vestibular group. And you see the exact same pattern, just magnified. So people that have vestibular loss, people that have dizziness respond much more to sensory perturbation. So you could see how they became gradually more and more different than controls, to the point where standing on foam with the visuals moving. I have to remind you, or I didn't say, but you could see it. So they're not standing feet together. This is supposed to be a comfortable stance. And they're not closing their eyes. It's just this minimal movement, and yet they still have this great difficulty of dealing with it. And so this is what kind of a sensory reweighting problem looks like. Now let's look at the small group of patients with single-sided hearing loss, because this to me was a bit of a surprise. I kind of expected the hearing loss folks to be here in the middle, but they went the other way. So when you look at sway, static and dynamic, they actually did not change at all. So this is no change in response to visual stimulation. And actually, even on the foam, they had less change when we added the foam. And even on the foam, they didn't respond to the visuals as much. So, and again, this was replicated in all other outcome measures that we looked at, which suggests that maybe these patients with single-sided hearing loss are less, have less of a sensory integration problem, and maybe more. This is where we started thinking about attention. You know, when you see something like that, of not enough response to visual stimulation or any kind of stimulation, you think about what we call conscious movement processing. So I'm a person that thinks too much about my balance. I know people tend to think of sway as little is great and more is bad, but there's another side to it. So for example, people who have anxiety or fear of falling usually present like that, with reduced sway. Instead of going with it, I'm just going to lock myself. So this is the first pilot study, and this specific population of hearing loss on one side was not studied as much, but we think this is really interesting, and we're now running a larger study with the same, so people with single-sided deafness, unilateral vestibular loss, or controls with different sounds, to look if this indeed holds. I think I already went over all of this. So finally, I want to talk about some practical implications. So are there things that we can do already? So even while more research is being conducted to understand the nature of the relationship between hearing loss and balance, it is already known that people with hearing loss may have balance problems, or I could also word it that at least some people with hearing loss have balance problems related to their hearing. So what can we do? A lot of it is pretty simple. If you're a practitioner, it's about asking. If you're a person with hearing loss, is about going to be evaluated, right? So we need to ask patients with hearing loss about falls in the past 12 months. We need to ask them about fear of falling and dizziness. This is a really interesting point because, as I mentioned before, the people with hearing loss that I recruit are recruited from the physician's office. I work with Dr. Cassetti. She's a neurootolaryngologist at Mount Sinai, really an amazing partner. And once she started recruiting for this study, because we want to isolate dizziness from hearing loss, she asks people first about fear of falling and dizziness. And she, as someone who works with this population for a long time, was actually pretty surprised that a lot of issues come up when you just ask. We had patients who came as supposedly single-sided deafness, and then a lot of fear and avoidance behavior came up that they were not even realizing how much they avoid until we started asking. So it's really important to ask people with hearing loss about fear of falling, about dizziness. Remember, fear of falling is part of that vicious cycle that we want to break. I think these two things are easy, not costly, takes, just a couple more questions. Can we actually do a physical screen of balance? What if, that survey study that we're doing, what if every patient with hearing loss, as they're waiting for, these are simple timed tests, as they're waiting in the wait room, have a quick screen of their balance. We're not doing that as part of research, but could it become clinical practice? Simple tests like time up and go, 4-step square test. There are quite a few tests that are quick, not clinicians dependent. It's just a stopwatch and the time means a lot. So is it time to start physically screening these patients? Generally speaking, all adults age 65 and older need to be screened for fall risk annually. Should we start sooner in people with hearing loss? Should we do that? So there's patients that I showed you in their 20s. I don't think they are at increased fall risk today, but would they be when they're older? Should they start thinking about it, exercising, working on their balance more? Refer to physical therapy as needed. And I think there needs to be here an interdisciplinary approach. If we have time left, I could show you a little bit what's known about hearing interventions, right? What kind of interventions helps, but this needs to work in both directions. I'm a rehabilitation scientist. I'm the director of the PhD in rehabilitation science. All of our research is interdisciplinary. This needs to be interdisciplinary as well, meaning it could be solved by hearing interventions. It may also be solved by physical therapy interventions. So the neurootolaryngologists need to think about rehab and PT, and the PTs need to think about hearing loss and screen for and potentially send them for hearing interventions as the next. There currently is no evidence. So in 2021, there was a paper that said that there's no evidence that all individuals should be screened for hearing loss. But when we have patients in PT that come for their balance, should we check hearing? So these are some practical implications that we can already do. I want to conclude by, I mentioned my team quite a few times, but I want to give all of them credit. Kathy still didn't send me a picture. Some people like having their picture taken more than other, but Brian Heisek is the Senior Director of Ambulatory Care Operations at the Ear Institute. Maura Cassetti, she's the Director of the Ear Institute. Jennifer Kelly, the Supervisor of Rehabilitation Services. Catherine is the Supervisor of Audiology. So this is my clinical team. And then at NYU, I have the incredible Ken Perlin from Computer Sciences, whose lab and students kind of designed the whole, all the virtual reality applications that we are using here and other studies as well. Against Karoginska, that she and her students have an ear that, and can hear things that none of us can, but really amazing team. And then Daphne that has been with me from day one at NYU. I never designed a study without a statistician. I also have a great team of students. Lilaz and Brittany are PhD student in the PT department. John, PhD student in rehabilitation science. Drew is now a postdoctoral fellow, and Sarah and Andrew are PT students. And we have a research lab. You are welcome to check it out. You're always welcome to reach out to me if you want to participate in studies. We're always looking for healthy controls or people with hearing loss. So before we see if we can get to some intervention stuff, maybe I'll start answering a couple of the questions in the chat. And if there are more questions, please send them along. Is there a percentage of falls associated with vestibular disorders? That's a super interesting question. So I took the hearing angle. What I could say about vestibular disorders. So a study from, this is now quite a few years, I think something in the 2000s, said that vestibular loss increases one's risk of fall by 8 times. If someone has vestibular loss, they're 8 times more likely to fall. But that study measured vestibular loss as inability to stand on foam with eyes closed. So this may or may not reflect vestibular dysfunction because, as I said before, there could be other reasons why people cannot stand on foam with eyes closed, but certainly that study is out there and is heavily cited. Interestingly, in our experience, and as I mentioned, I work very closely with a vestibular clinic at Mount Sinai, what these patients report is actually not falls, but discomfort, anxiety, dizziness in these busy, complex environments. And so they either avoid them, which is a whole problem by itself, or they're being very careful. I have to say, we were surprised by when we saw that people with hearing loss actually performed slower than some of the patients with vestibular loss. And I wonder if it's because with vestibular loss, as I showed you, by the way, in the graph, it's a lot about the sensory integration. So when you look at tests like the time up and go and the forceps square test, the environment is well lit, the floor is smooth, it's a very predictable test. So they do well on these tests because, especially those with unilateral vestibular loss. Bilateral vestibular loss is a bit more complex. But those with unilateral or disorders of that kind, they're fine. Their problem comes up more when we change the visuals, when we changed the environment. There's so I hope this answered Dr. Horwitz's question. In order to determine any loss of hearing, does NYU provide audiology tests? So I work at the NYU University. So we at Steinhardt, we are Department of Physical Therapy for educating physical therapy students. We're not part of the hospital, so I'm sure the NYU Health Center has audiology tests. And we, in our current study, every control that volunteers and people with hearing loss and vestibular loss, we run a full test of caloric test, which looks at the vestibular system, video head impulse test, also looking at the vestibular system, as well as full audiogram to make sure that people have normal hearing or severe hearing loss on one side. And I just got a response that the Department of Speech and Communication Disorders at NYU actually offers hearing screen that's done by their students. So that's awesome. Thank you, Sonia, for sharing that. So that's a much better answer than I had. So I should have said, yes, NYU does provide audiology tests. That's actually great to know. Any other questions?
I have, this is Victoria Ravis. I have one broad question. Is there, have you started to do anything yet to control for recency of hearing loss? In other words, is it possible that people adapt over time, and individuals who may have had deafness for a long period of time may not be experiencing the same type of difficulty with balance?
The chronicity question, that's a great question. Actually, at least in the study I showed, these people had hearing loss for over a year, and many, there were just 9 patients, but most of them had it since birth, or could not remember exactly, but since they were very young. So that these are definitely people with long-standing hearing loss, and the majority of our studies have people that include people that have had hearing loss for a while, even just because of the nature of how hearing loss is treated, right? So when patients come in to doctor, so how we recruit them, when patients come in to see Dr. Cassetti, they and complain of a new onset of a hearing loss, she'll first try to treat it, maybe a steroid injection, if it's really this sudden hearing loss. And oftentimes, at least unilateral hearing loss is sudden. And so we're not going to test them until at least 6 months out, once they tried therapy and saw that hearing didn't help. Because if their hearing improved, then that's great, but they don't need us. So the literature I presented about hearing loss, and I'm going to say it again, it's this large survey study, and there are a lot of things that they did not control for. So they didn't necessarily control for bilateral versus unilateral hearing loss. They didn't control at all for type of hearing loss or onset of hearing loss. There are some studies that has self-reported hearing, and I'm sure people in audiology wouldn't feel comfortable with a test of self-reported hearing as their outcome measure. So there is still a lot of work to be done to clarify all of these roles. But these studies typically include people that have long-standing hearing loss. I actually can kind of piggyback on that question and talk a little bit about interventions, because one of the things we see with interventions is that we need some time. So it's almost the opposite, but so especially in cochlear implants. So in 2021, there was a systematic review looking at whether hearing amplification can improve, they call it presbyvestibulopathy, which meaning balance problem related to hearing and a risk to fall. They had 10 studies that they reviewed, and overall hearing amplification helped to improve balance, especially with a cochlear implant, but it took some time. And we in our lab did a case study. So we have a kind of a pilot study going on where we're monitoring patients before and after a cochlear implant. So one of the patients completed, and it was interesting. He's 56. He actually has Meniere, so it's also a vestibular condition, and had a special surgery, including a cochlear implant. And it's quite common with cochlear implant that balance outcomes actually get worse at first. But then when he came after 6 months, he had zero dizziness. So he had some dizziness coming in. It got a little worse after 3 months. And then after 6 months, he was so happy, zero dizziness, high balance confidence. And he was more stable on our kind of postural sway analysis. So there's certainly a time component in terms of how long you need to wait with interventions. Another systematic review look at hearing aids while I'm here. And there really isn't enough, because you're asking about how long people have had their hearing loss. The question with hearing aids are these people hearing aids users? So they're used to it, and then you take it away. So of course they're not going to feel comfortable. Or is it new introduction, and then it takes time to get used to it? So the literature on hearing intervention is still lacking. Some studies showed improved balance with hearing aids, but it's not, it's certainly not conclusive yet. So I hope I answered your question, Victoria. I'm gonna answer another question. We've been talking about how hearing loss related to fall risk. How could we promote the use of hearing aids in elderly when some of them may resist in using the aid? So that's exactly, I think that's kind of why we're here, right? That's why we're doing the thing we're doing. We want to promote, healthy balance, healthy hearing. And at least we in a group believe that if we had, clean, mechanistic, controlled studies that consistently show how hearing aids can help balance, we could then, start promoting them more. We already know about the importance of hearing aids for communication and participation, but I think supporting this with evidence related to falls or balance could be pretty powerful. And also, well, I'm not a policy kind of insurance or hearing aid design kind of person, but just yesterday I worked with a patient who did not use a hearing aid for a while because when she put it on, it made things really loud and she couldn't control it. And then she came yesterday and she said, there's new technology of this cross hearing aid, and she's so happy with it. So I think we need to go, to move in all of these channels at the same time. So strengthening the evidence, showing the mechanism, but also improving the hearing aids, reducing cost, making it more accessible. I think, and there are people here from different fields, so I think we should all be doing this together. Thank you for your question. Any other questions?
Okay, I think you've answered all the questions and comments. It was a very provocative and informative presentation, and I personally am very much committed to a cross-disciplinary or interdisciplinary approach towards understanding issues and problems. And that's part of what we hope to do with the Aging Incubator, is to continue to foster this type of dialogue. I thank you very much for your presentation. I think we're all going to walk away with new insights and new excitement over the opportunities that NYU offers to advance people's wellness and integration into society. Thank you very
That's
much,
great.
Dr. Lubetzky.
Thank you for having me. And anyone in the audience, feel free to reach out to me. My first name at nyu.edu with any question, comments. I'm always happy to continue the conversation. Thank you so much for being here, and thank you for having me.
And thank you all for attending. And please continue to check our website for continuing updates as to our next series. Thank you.
Thank you, everyone.